Welcome to this episode of the ASHA podcast. I'm Fred Wyatt with the American Sexual Health Association, ASHA, and today we're focused on the most recent surveillance report on sexually transmitted infections published by the Centers for Disease Control and Prevention, CDC. It came out in November this year, 2024, and is thought-provoking. There were more than 2.4 million cases of chlamydia, gonorrhea, and syphilis reported in the U.S. in 2023. That's the most recent year for which we have data, but the numbers suggest the epidemic might be slowing. All right, so there's a lot to discuss, and we're very fortunate to be joined today by Dr. Bradley Stoner, the director of CDC's Division of STD Prevention, and he's been a friend of ASHA's for a long time, including he was once the chair of our board. So Dr. Stoner, thank you so much for taking time to chat with us today.
Thank you, Fred. I'm delighted to be here.
Okay, so as I mentioned, there's cause for optimism because compared to 2022, the most recent data is showing outright declines in reportable STIs, or at least a slowing in the rate of increase. So I'd like to dive deeper into specific STIs. So let's start with syphilis. Overall, there was a 1% increase in syphilis from 2022 to 2023, but that's a significant drop compared to recent years. And also cases of primary and secondary syphilis, when it's most infectious, they drop at 10%. And notably, primary and secondary cases were down 13% with men who have sex with men. And I think that's the first decrease that CDC has seen in this group since the STI report has been issued. So a lot to unpack there. Let me catch my breath. Why do you think these overall numbers have improved, especially with the primary and secondary cases?
Well, thank you, Fred, for that introduction. And yes, we are optimistic about the numbers, but I will say at the outset, there's still a lot of work to do. We're encouraged by the early declines in primary and secondary syphilis, especially among gay, bisexual, and other men who have sex with men. And I'd like to point out the numbers can't really tell us why, but some of the potential reasons could include increased use of doxypep as post-exposure prophylaxis with doxycycline among some groups, as well as prioritizing and coordinating focus on the syphilis epidemic at federal, state, and local levels. And I'll point to the National Syphilis and Congenital Syphilis Endemic Task Force, which was convened late in 2023 by the Office of the Assistant Secretary for Health. So that has increased focus on syphilis, could be getting people tested at a greater frequency and getting them treated. And then there was an unprecedented but temporary infusion of funding into health department disease intervention specialist programs coming out of the COVID pandemic. So all of those things may have contributed. We're also seeing additional scaling up of funding for some sexual health clinics as part of the Ending the HIV Epidemic, or EHE, initiative. And finally, I would just say increased attention and action with regard to sexual health among gay, bisexual, and other men who have sex with men during the mpox outbreak in 2022. So I think all of those things put together give us insight into why these data appear promising. But as I said, we still have a long way to go to turn the STI epidemic around. And now's the time to capitalize on the momentum that we're seeing.
You make a good point about MSM. I was actually going to ask you if you found it at all surprising that the PNS syphilis numbers were down with that group, but it sounds like you've got some pretty specific reasons there. And it's amazing how one thing plays off the other, like the attention we're getting seeing around mpox can actually affect other areas of sexual health as well. So
yeah, I think so. I mean, from my perspective, the declines that we're seeing, particularly among MSM, show us what's possible when the nation prioritizes and invests in STI prevention. I'm fond of saying what we're seeing is a prevention impact. And these data arrive on the heels of important innovations. I mentioned doxypep, which has been shown to prevent recurrent bacterial STIs in persons with a history of prior STI, as well as the availability of new self-tests, particularly for syphilis. And point of care tests that can be done in clinical as well as non-clinical settings. Go ahead. I'm sorry, Fred.
Oh, no. My gears were just turning here because you're touching on a lot of things I want to come back to. So I'm just sort of making mental notes, but please continue.
Well, no, I was just going to say that it's important to remember that gay, bisexual, and other men who have sex with men still accounted for more than 30% of primary and secondary syphilis cases in 2023. So there's tremendous health disparity importance to the work that we do. And we're committed to keeping the pressure on to turn things around.
All right. One of the most tragic aspects in recent years has been the increase in congenital syphilis or syphilis in newborns. And it's especially frustrating because it's largely preventable, right? I mean, in the 2023 report, we see that there were a little less than 3,900 cases of syphilis among newborns. But here, too, there's some positive news because that rate only increased 3% nationally, which was a huge decrease from what we've seen, say, going back to 2019. I mean, why do you think the congenital syphilis numbers look better? Is it basically for the reasons you outlined, or anything specific to this?
Well, I mean, we're encouraged by this. I would have liked to have seen the numbers lower in 2023 than the previous year, but as you said, a 3% increase relative to 30% year over year increases, which we had seen in previous years. So we'll take that as maybe a bending of the curve. And still, these numbers remain unacceptably high. And because in addition to the nearly 4,000 congenital syphilis cases you mentioned, there were 279 stillbirths and infant deaths related to congenital syphilis. And this is very troubling because we know that 90% or more congenital syphilis cases can be prevented through timely testing and treatment. Now, we can't say for sure why congenital syphilis epidemiology has slowed in 2023, but we do know that this momentum cannot be wasted, and now's the time to keep pushing forward.
So my next question was going to be around pregnant people or those considering pregnancy. What do they need to do to protect themselves and their babies from syphilis? But you touched on it there, right? Timely testing and treating.
And even before pregnancy. So persons considering pregnancy, getting tested before pregnancy and effective treatment can prevent transmission to the fetus, and then timely testing during pregnancy. Because we know that if you have syphilis, you can pass it to your baby during pregnancy, and that's what we call congenital syphilis. And this can significantly impact the health of the neonate, depending on how long you've had syphilis or when you were treated. So timely testing and treatment can be really important. Some of the adverse consequences of syphilis during pregnancy are miscarriage or stillbirth, which can occur at any stage, really, and then prematurity, low birth weight, and death shortly after birth. So all of these things are preventable conditions that testing and treatment early before and during pregnancy can avert.
Yeah.
I don't know. Do you want? I can go on about congenital syphilis for quite some time, so I'm happy to tell you
Yeah.
why it's important.
I think you really covered the main points there, and it just resonates with me. Just, I mean, the consequences can be so dire and dramatic, but the solution is, I mean, I'm oversimplifying, but it is preventable, and it's, not exotic stuff, right? It's timely testing and treatment, and that's always what gets me. It's something we can really address so effectively, and when we don't, the outcomes can just be quite dreadful, and I just always get sort of caught up in that. But I know that CDC is making congenital syphilis an area of real priority, and I can see why.
Well, it's heartening for us that some of our partners, like the American College of Obstetricians and Gynecology, are now calling for routine testing of syphilis 3 times during pregnancy, which is at first prenatal visit, at 28 weeks, and then again at delivery. CDC has endorsed a version of that for individuals who live in areas of high morbidity. And unfortunately, it's not easy to tell, exactly where, if you live in an area of high morbidity. We do know that about 70% or more of the US population do live in areas where syphilis rates are higher than 4.6 per 100,000, which is our cutoff for high morbidity. And there we have a county locator that you can find out your own county and determine what your local syphilis rate is. But by and large, we think for many, if not most people, 3 syphilis tests during pregnancy is very, very valuable, particularly at this time when syphilis is widespread. We really need to do everything we can to test as many people as often as we can.
All right. Let me ask you about gonorrhea and chlamydia, because the STI report also includes data there. So there were 1.6 million cases of gonorrhea reported in 2023, about the same as the previous year, and just over 600,000 cases of gonorrhea, a 7% decrease from the previous year. So with gonorrhea, the numbers look better. For chlamydia, at least no worse. Any insights as to why we might be getting better footing with these two infections, or is it just really the things that you've talked about previously?
So we're drilling down into that, and we're trying to understand why now for 2 years in a row we've seen declines in gonorrhea. We did see a COVID bump. There was an initial decline in gonorrhea, both gonorrhea and chlamydia, and then a rebound that occurred for gonorrhea that surpassed the pre-COVID rates. And we're fortunately now we're back to our pre-COVID numbers of gonorrhea, which is very heartening. With chlamydia, we haven't really come back up. We took a COVID dip, and then we haven't come back up to that pre-COVID level, which tells me that we're not screening as aggressively as we did before the pandemic. So I think that's a part of the issue. I think the other issue is that we're paying more attention to STIs in general, that we've now been in a moment where we've had high STI rates for a long time. We're seeing greater awareness and greater detection and treatment of individuals at risk for STIs. So I think that might be part of it. As I said earlier, these are surveillance numbers. They tell us what, they don't tell us why. But some potential reasons for declines in gonorrhea might include the use of doxypep increasing among some groups. Now, doxypep has been in use for several years. CDC just endorsed it in 2024 with formal recommendations, but it had been previously used in many parts of the country. And it does have a prevention impact for gonorrhea, although less so than for syphilis or chlamydia, partly because of tetracycline resistance. We don't use gonorrhea, tetracyclines or doxycycline for treating gonorrhea, but there is a prevention impact that's seen post use of doxypep. And then also the funding that we had for expanding the disease intervention or DIS workforce might have been contributing to this by identifying individuals with disease and getting them tested and treated. So all of these things expanded access to sexual health services around the country and increased attention to gay, bisexual, and other MSM health as a result of MPOX.
Let me stick with doxypep just for a minute. So as you alluded to earlier, that's using the antibiotic doxycycline ASAP after condomless sex, I believe, but at least within 24 hours. Is that a fair summary?
It's actually 72 hours, and it's a 200 milligram single dose taken within 3 days or 72 hours of unprotected sex. It's been shown to be effective in at least 3 clinical trials for gay, bisexual, and other men who have sex with men, as well as transgender women. And we have endorsed it formally for CDC at CDC for those groups. There is less compelling evidence for cisgender men who have sex with women and then women. It's not something that we can formally recommend at this time. It can be prescribed as part of shared decision making between a patient and a client.
Sure.
So that's the background on it. We do recommend that providers discuss the pros and cons of doxypep with all of their gay, bisexual, and other men who have sex with men, as well as transgender women with a history of a prior STI in the last 12 months, because we think that this is the risk group that will most benefit from it. Some of the risks associated with doxypep, the risks known and potential risks, for example, photosensitivity can increase. You can get sunburn more likely taking doxycycline, but we're talking single dose medication as opposed to being on the medication for a long period of time.
Right.
Sometimes people get esophagitis or they get a gastrointestinal discomfort, and those can be mitigated with antacids or H2 blocking medications. Some of the unanticipated risks, of course, would be what we might be doing to antimicrobial resistance as a result of increased use of antibiotics. There's a lot of focus right now on antimicrobial stewardship and trying to minimize the use of antibiotics that aren't necessary. But in this case, we think the greater good is through wider use of this medication. We're monitoring, we have systems in place to monitor any potential negative impact on antimicrobial resistance as a result of doxypep use. And so far, we haven't seen compelling evidence that says that there's any concern that we need to be paying attention to right now.
There are a lot of moving parts to all that, Dr. Stoner. I'm I'm glad someone's on top of it.
Yeah.
And thank you for that explanation as to why currently it's only recommended for MSM and transgender women. And I'm sure you're looking at data as it becomes available with other populations, but it's good to know kind of where we are now, and we'll see where we go in the future. Let me ask you, this is a very basic question, but I know that gonorrhea and chlamydia are often asymptomatic. I mean, it's quite frequent that they don't have really obvious signs and symptoms. What kind of issues can be caused if gonorrhea and chlamydia are undetected and therefore untreated?
Yeah, gonorrhea and chlamydia are so important, and we spent a lot of time talking about syphilis, but I want to make sure we do cover the negative impacts of these serious STIs. People can face permanent health problems when gonorrhea and chlamydia go undetected. For women especially, untreated infections can cause pelvic inflammatory disease, which can be both clinical as well as subclinical. And pelvic inflammatory disease can be very painful, but it also can be can be mild in symptoms and can cause inflammation and then scarring of the uterus and the fallopian tubes. And this can lead to infertility due to blocked fallopian tubes, tubal scarring, or ectopic pregnancy, which can be a medical emergency. Both of these conditions are chronic problems of untreated gonorrhea and chlamydia. Also chronic pelvic pain, tubo-ovarian abscess, and so other kinds of complications can occur. And then for men, both infections can cause inflammation of the vas deferens and the testicles, which may require treatment. So epididymitis and other kinds of complications can result. Less common than we see for complications in women, but still not something to be taken lightly. And this can lead to infertility in men as well. So undetected, untreated infection are serious issues for us at CDC, and we recommend screening and treatment.
And that just gets back to the point why testing is so important, and that is a whole different conversation we could have. Just we could spend 30 minutes just talking about how to how to meet people where they are when it comes down to testing, and that sort of leads into my next topic. And you touched on this earlier, so I know the CDC has been talking about the need to meet people where they are with STI prevention and other services. And I wanted to ask you about some newer approaches and how we deliver testing and treatment services outside of traditional clinic venues. And you touched on that, I think, a little earlier when you mentioned like at home testing and things. So what's kind of cooking there?
Yeah, it's a great question, and it's something we're spending a lot of time on at CDC. This idea of reaching people where they are with STI care, both in clinical as well as non-clinical venues. So, for example, mobile vans that can provide screening and treatment and access individuals in other areas of service provision, such as substance use treatment facilities, shelters that provide services for unhoused individuals, emergency departments, urgent care centers. But lots of opportunities for us to do wider screening and treatment. We're paying attention to greater access to STI services in pharmacies and retail clinics. So now in November of this year, just last month, the very first self-test for syphilis is available in the United States, and you can get it at any local pharmacy or even online. And these are finger stick tests for syphilis that can help people identify if they've been exposed and need treatment. Now, the next step, of course, is linking those individuals to care, and that's something that we're trying to address as well. But tremendous opportunities now with point of care tests, both self-tests as well as provider-delivered point of care tests in clinical and non-clinical venues open up wider opportunities for screening persons for syphilis. And as well, we've had urine tests for gonorrhea and chlamydia for some time. These are not self-tests, but they provide greater access to services because it's easier to collect a urine than it is to get a full genital exam. So, greater use of those. I think that's going to be really helpful. And there are opportunities for self-collection of some of these specimens and provider sources that can accept mail-in specimens. So it's important for persons who do self-test at home or outside of a clinical venue to see a provider to confirm a diagnosis and to get proper treatment. But we're excited about these innovations, and yet we know more is still needed. better point of care rapid tests. We need data to help us support post-exposure prophylaxis in women and transgender men, and vaccine research, which is ongoing for STIs, kind of the holy grail of our field. If we could get a syphilis vaccine that works, and until that time, more accessible treatment for STIs, and destigmatizing these really important medical conditions.
You just said a very important word, and I want to follow up with you about that. So, for every discussion we have around clinical matters, we seem to have at least one more about shame, stigma, the relationships, how all that works. Would you talk about the impact of shame and stigma when it comes to accessing STI services, and maybe what can we do to help people feel more comfortable in starting these conversations in the medical office?
Well, we know that our field is one that is marred by these unfortunate issues of stigma and shame, and they can provide barriers to accessing services. I'm a medical care provider, and it's difficult to have conversations around sexual health with patients, both from the provider perspective, but as well as the patient perspective. And some of that has to do with the sense of stigma or shame around some of these conditions. I'm hoping for the day in which getting an STI test is as easy as getting checked for diabetes or cholesterol, that there's no shame or stigma associated with these conditions. But we know that these unfortunate perceptions can keep someone from bringing up STIs to their provider, may even prevent them from seeking care or going to a provider at all. And they can make a provider very anxious, or even too anxious to ask someone if they want to be tested. But the truth is that people deserve quality health care and sexual health care to live healthy lives. And conversations like this are a great way to tear down stigma and shame associated with STI. We do have good conversation tips for talking with partners and providers that are available on our website. So this can help destigmatize
Sure.
these conditions.
And you touched on something I think that's really important there. It's not only the patients who might be uncomfortable, the provider may be as well, you know. Um, okay.
Yeah, these are difficult
Yeah,
conversations, and what an innovation that we've developed at CDC are conversation badges that you can add to your online dating profile about STIs and about the need for prevention. And we acknowledge, or these badges can acknowledge that sexual health is an important topic and can invite like-minded matches to discuss STI prevention in a casual, judgment-free way.
that's great. You've mentioned a number of resources, and we will link to those all in the show notes. So thank you for that. The last topic I have for you is health equity. So despite some, good news, some cause for optimism in the report, we know that some populations really still bear a disproportionate brunt of STIs. Teens and young adults, MSM, as we talked about, pregnant people, communities of color. We could go on. Would you just touch on what are some of the factors that maybe make these groups more vulnerable to STIs, and how do you think we can address them?
It's such a difficult question, Fred, and it's been such a long-standing problem for our field that we know that STIs are widespread, but they're not equally spread in the population. They're not equally distributed. Some groups, as you mentioned, bear a greater burden of disease than others. So our new data show that these STI inequities do persist, and some groups are more severely impacted than others. I do think that these differences are due in part to decades of deeply entrenched social factors that create greater obstacles to quality healthcare services, making it difficult for some people to stay healthy and protect themselves and their partners from STIs. So such issues as poverty, racism, a lack of access to healthcare, health insurance issues, and a variety of other issues. But we do know that the solutions include empowerment at the community level. And this includes listening to people and taking action within communities to address STI disparities. We see some amazing prevention work happening around this country every day at the local level. So CDC can provide leadership and guidance and oversight, but the real prevention work is happening in communities all across the country. So factors like poverty, addressing limited access to healthcare and health insurance. These must be prioritized and addressed beyond public health systems. We have a widely distributed health system approach in the United States, and there's not a one-size-fits-all solution in any particular community. But we do know that empowering people with the information and tools they need to protect themselves and their partners can go such a long way to help reduce disparities. So wider access to DoxyPEP, for example, wider access to testing and treatment services. And I don't want to not mention condoms. I want to emphasize that condoms still are
Yes.
important part of STI prevention. We have not talked about that yet, but really we need to use all the tools in our toolbox to help promote a healthier populace.
That's an excellent point, because if somebody may be on, like, say, hormonal birth control, they may think, hey, I'm covered, but they don't realize you need the condoms for the STI prevention angle. So thank
Yeah.
you for mentioning that.
Yeah.
So we know there's a lot of work to do, and you touched on that, and we really appreciate what you and everyone at CDC is doing here. Thank you for that. Dr. Bradley Stoner has been our guest today. He is the director of the STD Prevention Division at CDC, and we appreciate your time. Thank you so much. And we may want to come back to you again sometime. I hope that's okay, but there's so many things to talk about. We appreciate you being with us today.
Thank you for the opportunity to really highlight some of the advances that we've made in STI prevention, as well as the challenges that face us in the future.
Absolutely. And thank you, intrepid listener, for tuning in. So in the show notes, as I mentioned, just on the page where you access this episode, we'll have links to data and resources, including CDC's fact sheets on congenital syphilis, clinic locators to find free confidential testing, and some of the other things that Dr. Stoner touched on. So click to get all of that. Thank you for joining us and for tuning in. Keep checking back. We're going to be rolling out a lot more resources, and we will see you on the next episode. Goodbye for now.